Hi, thank you to all of you. My question is kind of twofold. I have Chiari, I've had numerous surgeries, and I have a 9-year-old son who has also been diagnosed. How often are you seeing, if you are, children who are being diagnosed who also have been diagnosed with on the autism spectrum? On his autism diagnosis, a number of his marks, I guess, that helped him get in there were some visual motor issues, which also could be attributable, some handwriting issues or hand weakness. And he also has some vision issues, and he's seen an ophthalmologist for some compression of the optic nerve. So we're saying, is that Chiari or is it autism, and where do we draw the line? Will we ever know? Do you guys have opinions?
Has he had a brain MRI?
He does. 2 years ago, he had a very minimum herniation. It's about 5 millimeters. It has increased to about 7. We don't have a sitting MRI yet.
Yeah, let me address a couple of things there. I pay no attention to numbers on kids. Okay, you measure your fingers or toes, everything should grow as they grow, right? So 5 millimeters to 7 millimeters over the age of 6 to 9 probably is insignificant. And so it's important that you have the radiologist or somebody look anatomically. Was it at C1? Was it at C2? How did it change anatomically? So numbers are much less helpful in my experience in kids. These 5 millimeters numbers we're talking about, Cormac has a number of good things in kids, but again, that varies there as well. So I don't pay as much attention to the absolute number. In terms of autism spectrum, I have a handful. You're looking at a couple percent autism spectrum diagnosis in the pediatric patient population, 1% 5 millimeter cerebrotonsillar ectopia. So there's going to be some overlap. I can think of 3 or 4 kids who are autism spectrum who are having clear Chiari symptoms. I've decompressed. It didn't affect their behavioral issues at all. In terms of the overlap, I think that's just going down with your physician and trying to figure out what goes where, and you may not be able to get a definite answer there.
A quick question about the tether cord. I was curious, I see a lot of children. Do you guys check that in adults and things like that?
We do. It's a pediatric problem, and typically the symptoms have been going on since childhood or early childhood.
Okay. And then another quick question, for therapy-wise, what do you recommend the physical therapists when they have patients and that disorders?
It depends on, the individual patient that you're seeing. In terms of tethered cord across the board, if you include the spina bifida patients, for example, a lot of them will have tethering and will have recurrent tethering, and they actually improve with physical therapy and don't have to be untethered over and over again. Strengthening of the core, leg strengthening, range of motion, all helps. But then if it doesn't help, then we have to address whether this person is retethered or not. A lot of the time, especially after the second untethering or more, patients will get weaker. The nerves kind of get shocked. They'll get a little weaker. They'll have some sensory deficits. And if they're kids, they may have paresthesias. They may not want to walk, and they have to be kind of pushed, and that's where physical therapy helps us.
Hi, just a couple of quick questions. So I know you guys were talking about the smaller syrinxes, and if it was typically under that 3 millimeter diameter that you would not operate. Are there any circumstances where there would be any operations for that sort of thing when a tethered cord is ruled out, Chiari is ruled out? So that would just be management at that point?
Yeah, just to clarify, I think the discussion about 3 millimeters was whether you could even call that a syrinx or not. And many physicians would not call that a syrinx if it was less than 3 millimeters. If it's over 3 millimeters, there'd be widespread agreement that you could call it a syrinx, but I think for many people, it still wouldn't be a surgical situation until it was significantly wider than that even.
Okay, awesome. And then just the other thing, as far as untethering, if you do have that untethering just as a young adult, what is the incidence of needing more surgeries in the future?
It depends on what type. The occult tethers that I was showing you, the thickened phylums, those usually don't require a second operation. The large spinal cord lipomas, the transitional lipomas in which all the nerves are all wrapped around and going through the lipoma can kind of grow back to some degree, and it can retether. The patients, like the little girl with the large epidermoid tumor in the hair and the skin elements, unfortunately, those tend to really ferociously scar, ferociously tether, and they have to be done sometimes more than once.
The best evidence
you.
right now is that the lifetime retethering risk for the big lipomyelomeniingocele type of tethered cord is about 25% over a lifetime. For the fatty phylum cases, we used to say it was 0. Now it's probably not 0. It's like 1 or 2%, at least in the Chicago series, which was the biggest. And that's one of the arguments for not operating on these at all unless there are obviously symptoms and things that you can actually see on the MRI scan, because you're changing a situation that has a really good natural history when left alone to a situation where there's a definite failure rate post-surgery.
I'd like to put a different view on it. I think that in this case, the case of the transitional lipomyelomeningocele and the spina bifida patient, the myelomeningocele patient, I think the data is pretty clear that mechanically they've retethered within days or weeks of the surgery. Yeah, so clinical deterioration is maybe 20% in those cases. I agree completely. But I think that the data is pretty high, that the cost of reoperation on that situation is really high. And the loss of neurologic function after redetethering, that patient is pretty high. And I think the new world is to do what they call a reduction. Anyway, you actually take off part of the skull, part of the spine, and then fuse at that level, and it reduces your height by 1/2 inch or 3/4 of an inch. But it doesn't involve redoing the interdural things, and is therefore much less likely to cause neurologic dysfunction as a result. And in somebody that's not growing, the stretch off of the nerve roots with that is very, very effective. Do you have any experience with that, Cormac?
Yeah, so our adult spine surgeons in my department do that operation and have recommended it. And so recently, for our multiple repeat tethered cord patients, they'll see me and I recommend a repeat untethering, and they'll see the spine surgeons who will recommend the reduction spondylectomy. I still do the repeat untetherings, and I think it works okay. We actually published on that about 10 years ago, and it's true there are risks, but the risks don't seem to be any higher the second or third time around than the first time around. Having said that, the spine surgeons love the reduction operation. But, that also has a certain set of morbidities that I think are pretty significant.
I had a question for Dr. Gilmore.
Yes.
Over here. Holly.
Oh, okay.
In the cases of the occult, more tethered cord, maybe in the older population, do you see any value in doing prone and supine MRI imaging to assess movement of the conus? And are there any physical findings such as, pelvic traction or spinal flexion and extension, and possibly generating symptoms that you would do in physical examination of individuals that you're considering, whether it's occultly tethered? And do you do urodynamics on all the patients?
Okay, so there's several. First, the prone and supine. I've done it, but at the end of the day, it doesn't change whether this person is symptomatic. whether they're consistently symptomatic and whether we have any other reason for the problem. If someone is incontinent, that is a major deal. If it's worsening incontinence, if it's sexual dysfunction, if it's repeated urinary tract infections and kidney infections and so on. So movement of the conus wouldn't sway me away from operating as much as what the person's clinical symptoms are, whether they're hyperreflexic, whether they have progressive scoliosis and all the other things. They usually do have traction signs on exam if they are symptomatic. And then the third question, sorry. Oh, yes, commonly, yes. And it's very useful, especially in kids also. It's very useful to get urodynamics beforehand, before surgery, and then afterwards, a few months out, to document what the baseline should be. That's really important in the ones with the large lipomas too, because they are baseline kind of abnormal.
I think just, a comment about that. The main problem with using symptoms as a basis for surgery and something like a occult tethered cord with normal MRIs is the symptoms are extremely nonspecific, and even the urodynamics are extremely nonspecific. And natural history is really good. Specifically, when you look at incontinence in childhood, it's extremely common to have incontinence in childhood, and it's extremely common for that incontinence to just get better spontaneously. So it's very difficult to study if we're actually benefiting anybody. The main proponent of that operation for the last couple of decades was Paul Steinbach, who talked for a long time about organizing a randomized trial for these kids with normal MRIs and good clinical signs of tethered cord syndrome. And he did that trial, and it showed no benefit whatsoever. Unfortunately, it was published in the urology literature, so I think nobody really talks about that trial much. But it's the only trial on this particular problem, and it shows that surgery has no effect.
Actually, the study showed that there was no long-term effect in urodynamics changes over a short period of time, which is only a year. So if you're talking about children and following children from birth to 18, 20 years old, you can't say that study showed no benefit.
Yeah, well, what it did show is that people who had surgery had the same outcomes as people who didn't have surgery in terms of the urological improvement. You're going to see urological improvement in people who are children with incontinence. If you look at a whole population of children with incontinence, they're going to get better by and large on average. That's true in whether you untether them or whether you don't untether them.
That's true depending on their etiology. If they have a neurologic problem causing incontinence, they're not going to get better on their own.
There's no doubt that's true. The problem is we can't tell who those people are on the basis of any current exam or technique or study.
That's true.
Yeah.
Are there current studies going on, active studies for the tethered cord
In terms of,
that we can participate in?
whew. Current studies for, the problem is tethered cord is so, it's so widespread, as far as what the problem is. Our literature is mostly really from the 70s, 80s, and 90s showing benefit. And there actually was a study from U of M, and I think it's from the 80s actually, showing that patients who were untethered over and over again actually still got better, primarily with respect to back pain, but secondarily with respect to function.
Yeah, that was my paper, and I agree with that.
Oh, that's funny.
But we're talking about separate things. I think everyone agrees that people with tethered spinal cords. Yeah.
And so that was the 90s, not the 80s.
Right, it was the 90s for sure. Everybody agrees that people with tethered cord that you can see on an MRI, that you can document that's symptomatic, is a surgical candidate, and that there's going to be an improvement there. I think the only disagreement comes in the so-called occult tethered cord syndrome that nobody can see, and there we're just making guesses, obviously.
Well, it's
So
not
that's
films that nobody can see, Cormac. It's films that you don't agree with.
Well, okay, and radiologists don't agree with, and 99% of surgeons don't agree.
For having Chiari and/or
And so,
PDS
part of the frustration is you saw the NIH, I can't remember who put that up.
They say,
Yeah.
are you diagnosed? Well, then sorry, you can't participate.
Right.
If you're not diagnosed.
Right, so there's nothing active currently is the answer.
Is there anything that we can sign up for through any of you?
You can petition ASAP to see if they want to start a
It's hard to find because there's so few doctors who are specialized in it, and there's so many of us who we've been many years.
Yeah.
You know, you have nothing wrong, and then to finally find you, it's wonderful to come here once a year to be able to find somebody who says, hey, we know what you're talking
Yeah,
about.
well,
We know what we're talking about.
It is frustrating, though. We talk about the failure rate in surgery and where we are. We're still in our infancy. Like I said, we've in the last 25 years, we've seen dramatic changes in the treatment of both Chiari and tethered cord, and we're still learning.
I mean, when people here that's only been here have been diagnosed in 2 years, 3 years, 4 years. Mine was almost 15 years ago, I had surgery. And all of a sudden, it's like, oh, well, we don't do this anymore. Oh, man. So, but I feel good some days, you feel terrible. But I would love to be in a study to go, I have 17 billion other things wrong. And they go, well, that was part of it. No. Well, it is now because, like I said, it's in its infancy. So to see something, somebody was going to say, the Sarah syndrome. With Carius, with Dr. Ari, said something about Sarah syndrome. Do you share that with your other doctors, with other people, or is that just something we use in your own?
Well, I told you, I think we have a moral obligation when we come up with something new to get it out as much as possible. Fraser Henderson has an article in the literature now. We're in the process of looking at the last 2 years of our experience with it. I've been to at least 4 conferences where this concept has been discussed. And Fraser does 2, and Paolo does 2, and Roger does 2. I mean, that's why I brought that thing up about the Max Planck thing, about the fact that the skeptics will die and there will still be somebody left standing. And there's always from a new idea to any possibility of acceptance averages at least a decade. It's never less than a decade. And so it's just a matter of you have to keep working at it and try to commit to get other people to look at it with a new eye. And I just think that's critical. It is essential that new concepts be submitted to peer review, and that they be reviewed by peers, people who care about these conditions, and assess them. And the need for statistical measures is really important. That's why the NIH common element creation is so important, because we all have to be talking the same language. Everybody has, the name Chiari is the worst thing in the world that happened to all of us in trying to figure these things out, because everybody has a different, is it a real Chiari or not? What does it mean, is it a real Chiari or not? Anyway, you hit a button, I have to calm down.
I just have a comment on the side. Were you at the meeting, Brian Flint's meeting in Syringomyelia?
No.
Unfortunately, Paolo's not here. To
Yes, he
speak for
is.
himself. Well, then speak for yourself. No, I was just going to say, we were discussing this, and Paolo was very happy about the fact that there was a lot more widely accepted ideas about craniosacral instability in the British population of neurosurgeons at the meeting. You want to say anything further?
So I just came back from the International Chiari and Syringomyelia meeting, which was in Birmingham, United Kingdom. Was organized by Dr. Flint, and was a sort of a follow-up to the meeting of last year in Long Island, ASAP, which was both national and international. So if many who have followed the proceedings of last year, there was a major fight, actually, in the open between the people from the United Kingdom who are extremely skeptic about the concept of craniocervical instability and complex Chiari, and the people of the United States like myself, Dr. Rekate, and others who are obviously have been seeing it, could not unsee it. The thing evolved during the fall with an article on the British Journal of Neurosurgery, in which the leading neurosurgical experts in the field of Chiari wrote a paper saying, we heard what's going on in the United States, we're going to be willing to look into it, but don't blame us if we're skeptic in the process. And Dr. Rekate 2 months later wrote a reply just making the counterpoints. At this meeting, which occurred last week, there was a radical change in position. There was an entire morning dedicated to craniocervical instability, craniocervical fusion, and for the first time in, I guess, 25 years or 30 years, 2/3 of the neurosurgeons in the United Kingdom who had traditionally left the dura open as an homage to Dr. Bernard Williams, who was the pioneer of modern neurosurgery in Chiari. The 2/3 of the neurosurgeons in the United Kingdom are now closing the dura with duroplasty. So things do change, and not necessarily happen overnight. It takes about 10 years for certain concepts to go among experts, another 10 years to percolate down, another 10 years to go to the standard neurosurgeon who's in the, at the corner.
Okay, we have one last, okay, two more.
Just a quick question. How often do you see, or if ever, thoracolumbar syringomyelia associated or just in conjunction with tethered cord? And if you do see it often, do you think that there could be some sort of cause and effect with that, or is it just kind of maybe incidental?
So I see it probably 25% of the time. Sometimes it improves after surgery, but I think more globally, this is an abnormal spinal cord. So there's a syrinx, there's a distal myelocystocele, which is a fluid collection at the end. And you can see a lot of the time an abnormal kind of configuration of the central canal, of the lining of the canal, indicating that this is a long-term insult, probably from in utero. So I think it's just a sign that overall this is an abnormal spinal cord.
That's also that can be called the ventriculus terminalis. It's an embryologic condition that leads to a focal distension of the central canal in the area of the conus medullaris. And I think that one has to give some credit to that as being a potential radiographic sign. And when you send, it's important because we've published on the fact that when syringomyelia doesn't, after a good Chiari decompression, does not get better, and it's a holocord syrinx all the way down, we will sometimes cut the filum terminale and send the specimen to the pathology, and they can see the syrinx going all the way down into the filum terminale. So it's called a ventriculus terminalis, and I think at least it requires some looking at, number one. And number two, you can see the remnants of the central canal all the way down into the conus. And it's sort of like doing, the effect has been really quite remarkable, and it's like doing a third ventriculostomy. What you're doing is cutting the bottom off a water balloon. And so I think it's something to be looked at, and we've just published that in Journal of Neurosurgery shortly ago.
Okay, last question.
When you're talking about the occipital cervical instability, are you mainly talking about EDS or any connective tissue diseases?
If you're around at 4 o'clock this afternoon, there's a panel on that very question. I think we'll probably hold that till then. If you're not going to be there, we'll ask. Okay, good.
But I don't have EDS, I have stiffness.
No, it can be in Marfan's, it can be in all sorts of things, and sometimes you just don't know what the genetic marker is. But joint hypermobility is the key.
And then the other question is, once you beat in decompress once, can you do, is it possible to have two of them?
Is it possible to have a second Chiari decompression?
Yeah.
It's fairly common.
Yeah.
But I heard yeah.
Well, there are people who wash their hands of it, but that's another matter altogether.
I'm presenting at the Congress in the fall a series of about 70 patients who've had at least two. I hadn't done the first one, but people had come to me, had previously been decompressed. So anywhere from a total of 2 to 5 decompressions. And actually, what I found, the biggest question people always ask is, if you've had a decompression, are you definitely going to keep having them? Are you going to keep forming scar tissue? What's going to keep it from forming? That actually doesn't happen. If you get it really opened up, and then the only thing I have seen that really helps as far as preventing a recurrence is if the graft is big enough that it's almost like a water balloon. So there's plenty of fluid swirling around the brain so that it can't stick back down. And it almost doesn't matter what graft is used, native tissue, bovine pericardium, artificial, as far as whether it's going to stick down, it's whether it's too tight.
We'll squeeze one more question in, and then we'll take a break for lunch. I just want to remind everyone that following lunch, we'll meet back here at 2 o'clock, and then we'll get going.
Hi, Rachel. Really Sarah, but my name is Rachel. I don't know if this further clarifies the initial question that she was referring to, but my understanding in the Ehlers-Danlos community is a lot of decompressions fail because of the potential of cervical instability. So by what you're saying is that
I'm admitting that my patient population isn't a standard
Sure.
review of the entirety of what's wrong with you. Because of Dr.
Sure.
Millerat's article, we have been a receptacle to the EDS population, and I know that my denominator is really false.
Of course.
But it doesn't mean it doesn't exist, and a lot of the EDS patients, when I see the EDS patients, many times they show beautiful, what looks like a beautiful exam of a good Chiari decompression. To me, a good Chiari decompression means there's a cisterna magna. That means that there's some spinal fluid behind the cerebellum, and that means that you've done all you can do there.
Right.
But if their head's falling off, then that's another matter altogether.
Correct. That leads me to the root of the question, is that once you fuse there, what have you seen in your experience in terms of having greater issues with instability lower down, and then as well as if there can be Chiari causing, ADS causing Chiari, what are the chances of it reoccurring given our tendency to have faulty
of the
tissue?
patients I've taken care of, the problems have all been related to the occipital screws. It's very, very hard. We've had to modify it partly because of Paolo and partly because of Justin Vero Janapa, who's going to be my person who's going to take my world away after I'm done. We now do shorter fusions at the condyle, and that has made all the difference. So as far as what you have is adjacent segment disorder, and in 200, 150 of these patients, I've seen it once.
Thank you.
I'll just finish with this because I know we're running short here, but I think we have to clarify, short of craniocervical instability or spine issues in the adult population, without a complication, recurrence of Chiari should be very rare. Having 2, 3, 4, 5 surgeries should be rare, short of if there's an immediate complication with a CSF leak, pseudomeningocele or something like that. That is not a common, if you're on your 5th surgery after a straightforward surgery, and I completely agree with you, keeping that very patulous, it almost eliminates the quote-unquote scarring for need for recurrent surgery.
Is that accurate in the subset of the EDS community as well, or just generalized?
Actually, a lot of those patients had EDS, and as you would expect, because they're more prone to complications, problems with healing and scar. But those 70 were over 17 years. So yeah, this is not a common thing.